Namaskar, Hare Krishna. Very good evening to respected teachers, mentors, mentees, speakers, and the lovely audience for the today's symposium. Now, this is the second episode of ISCCM Journal Club, which was initially conceived as a brainchild project of our President-elect, Dr. Ranveer Singh Tyagi, sir. Now, this activity is an honest attempt to simplify the evidence-based medicine to the bedside medicine with the aim to achieve not only the clinical excellence bedside, but also to reach to the corners of this country and to homogenize the critical care practices, right? With this, I would like to request Dr. Ranveer Singh Tyagi, sir, to address us with some few words. Please, sir.
So, welcome you all on this second journal club of ISCCM. ISCCM started every Friday, 7 to 8 p.m. One is the scientific program. On the first is different, second different, third is different, and fourth is different. So, on the second week, Friday, 7 to 8 p.m. is the journal club. And thanks to coordinator, Dr. Manish and Neeraj, doing very hard effort for making this grand success. And thanks to Rakesh sir for giving time. And thanks to Saurabh and other team member who are presenting. So please go ahead with my best wishes.
Thank you, Dr. Ranveer, sir. And of course, this whole exercise is going to be executed under the direct guidance of our chief expert, Professor Rakesh Garg, who is a lovely teacher. And he's a doyen in the clinical research and methodology in this country. And everybody knows Dr. Rakesh. He hails from the All India Institute of Medical Science, New Delhi. Now, as far as today's session is concerned, we have two speakers and two respected mentors. The first paper, the critical appraisal, is going to be from NEJM, and it's going to be by Shivani, Dr. Shivani Fotedar, a great clinician, very hardworking. And she is doing her DRNB in neuroanesthesia at Artemis Hospital, Gurugram. And the mentor for this session is going to be Dr. Saurabh Anand. Dr. Saurabh Anand is the Chief of Neuroanesthesia and Neurocritical Care at Artemis Neurosciences, Gurugram, right? And the second paper is going to be by Dr. Abhinandan Bora. Dr. Abhinandan is a great friend and a very bright emergency physician as well as critical care physician, Abhinandan. And he is basically working as a consultant and assistant professor in the Department of Anesthesiology and Critical Care at Shada School of Medical Science and Research, Uttar Pradesh, Shada University. And of course, our mentor for this session is going to be Dr. Rakesh, who has been otherwise our chief expert as well. This whole session is going to be moderated by Dr. Neeraj Kumar, as well as myself. Dr. Neeraj is the associate professor in the Department of Anesthesiology and Intensive Care at AIIMS Patna. So over to you, Shivani. Please go ahead. Just remember, in the interest of time, your duration will be for 20 minutes, please, each. Thank you.
Right, sir. Thank you for this kind introduction, sir. And I'm grateful for this opportunity. And I'll be presenting today antibiotic treatment for 7 versus 14 days in bloodstream infections, the comprehensive analysis and critical appraisal of the same, the study having been presented in NEJM. So moving on, this study is also called the BALANCE trial. Why it is called the BALANCE trial is because the first initials of BALANCE stand for bacteremia, antibiotic, length actually needed for clinical effectiveness. This study was published in NEJM in November 2024, both in the print media as well as in the web, on the online journal. So bloodstream infections are a major cause of morbidity and mortality. Over 600,000 cases in North America annually with 900,000 mortalities. BSI remains a major contributor of antibiotic use in the ICUs. Now, challenges with antibiotic duration are that if we happen to use antibiotics for a shorter duration, they could lead to clinical failure, they could lead to relapsing infections or antibiotic resistance. On the contrary, if we happen to use them for a longer duration, they could lead to increased resistance amongst the non-targeted bacteria or C. difficile infection or adverse effects to the treatment. Now, talking about the Surviving Sepsis campaign and the quality of evidence, the latest that we have for adults with an initial diagnosis of sepsis or septic shock and adequate source control, we suggest using shorter over longer duration of antimicrobial therapy. But this evidence is weak and of very poor quality. So moving on to the existing studies that we have, the literature review that was done suggested that 7-day treatment has proven non-inferior for community-acquired and hospital-acquired pneumonia, uncomplicated intra-abdominal infections, and pyelonephritis and cellulitis. I have listed the studies about which I'm talking on the left-hand side of the panel. And the limitations of the past studies was that they excluded bacteremia cases, focused only on uncomplicated infections, and had a modest sample size. Now, the hypothesis of the BALANCE trial is 7-day treatment is non-inferior to 14-day treatment in hospitalized patients with bloodstream infections. So, the study design, the study type is an investigator-initiated, multi-center, open-label, randomized, controlled, non-inferiority trial. It was conducted across 74 hospitals in 7 different countries, and there was a steering committee involved which oversaw and governed the complete study. There was regulatory and ethical approval involved. Informed consent was obtained from the patients or the substitute decision makers. It was primarily a Canadian study, but the Clinical Research Network from Australia, New Zealand, and Australasian Society of Infectious Diseases was also involved. So moving on to the inclusion criteria, hospitalized patients with a positive blood culture for a pathogenic bacterium admitted to a participating hospital at the time of diagnosis was included in the study. Now, the exclusion criteria were obviously that all the patients who were already enrolled in the study could not be re-enrolled into them. And the other criteria was that severely immunocompromised patients, neutropenic patients, immunosuppressive therapy, immunoprosthetic heart valve, positive culture of contaminant, or patients having Staphylococcus aureus infection. So how was the randomization done? There was a web-based randomization with varied block sizes. 1:1 randomization ratio was kept between 7 to 14-day groups. Now, adequate treatment was defined as antibiotics susceptible to identified pathogens as per laboratory reports, and the selection of antibiotics, doses, frequency, and route of administration was at the clinician's discretion. This is a table which I have taken from the study where 36,637 patients were assessed for eligibility, but finally, because of a lot of factors that the patients had, only 3,631 underwent randomization. So they were randomized into 1,824 into the 7-day group, and 1,807 were assigned to the 14-day group. So the primary outcome was 90-day all-cause mortality based on the date of positive index blood culture. Secondary outcomes included death in the hospital, death in the ICU, relapse of bacteremia, C. difficile infection, secondary infection, or colonization. Moreover, treatment-related outcomes were also there: hospital and ICU stay metrics, treatment-free days, mechanical ventilation-free days, ICU-free days, vasopressor-free days. These are also a part of the secondary outcomes. Talking about the statistical analysis, sample size calculation and power analysis was done for 3,626 patients. The baseline mortality estimate was kept 22% at 90 days, and the non-inferiority margin was 4 percentage points, which was more conservative than the 10% used in other infectious disease trials. Very important for this study. The power 80% with a one-sided alpha of 2.5%, and loss of follow-up allowance was 5%. The additional analysis which were used were the intention to treat analysis, which was the primary approach. Other than that, the per protocol analysis included patients receiving treatment within plus minus 2 days of assigned duration, which meant that for the 7-day group, it was 5 to 9 days. And for the 14-day group, it was 12 to 16 days. And then there was a modified intention to treat analysis as well, in which there was an exclusion of patients who died before day 7. So the results and the patient enrollment, we'll talk about that. The enrollment period was from October 17 to May 5, 2023. October 17, 2014 to May 5, 2023. And this is the furthering of the same chart that I had shown before. So 1,802 had complete outcome data at the day 90 for the 7-day mortality for the 7-day leg, and 1,779 had complete outcome data for the 14-day leg. This chart tells us about the characteristics of patients, infections, and pathogens at the baseline. So what I want to highlight here is that 55% of the patients were enrolled into the ICUs and 45% were enrolled into the hospital wards. The most common comorbidity was found to be diabetes mellitus. Then the most common infections were community acquired, they being 75.4%. And the source of bacteremia was found to be urinary tract, it being the highest, 42.2%. And E. coli was found to be the most common pathogen found amongst all infections. So the infection sources and pathogens, the urinary tract infections, as I stated, made it 42.2%, followed by intra-abdominal and hepatobiliary infections, 18.8%, lung infections, 13%, vascular catheter-related infections, 6.3%, followed by skin and soft tissue infections, 5.2%. So talking about the microbial coverage, gram-negative bacteria were found to be maximally involved, E. coli being 42.3%, as stated previously, followed by Klebsiella, and then came the gram-positive monomicrobial ones, followed by the polymicrobial ones. Then now talking about the results or the primary outcome. So as I stated, there were 3 analyses which were involved: intention to treat, per protocol, and modified intention to treat. So from this graph, we can see that in both the 7-day and the 14-day period, the forest graph which is made is not touching the 95% confidence interval. So that straight away proves that it is an inferiority trial. 7-day, like the 7-day period is inferior to the 14-day, non-inferior to the 14-day period. Now, non-adherence of the protocol. In the 7-day group, the total non-adherence was found to be 23.9%, and in the 14-day group, it was found to be 16.5%. For the shorter duration, in the 7-day group, it was found to be 0.8, and 14-day, it was found to be 5.8. However, for the longer duration, the 7-day group had it at 23.1%, and 14-day group had it at 10.7%. Now, moving on to the primary and the secondary outcomes, the median number of hospital-free days by day 28 was found to be 17 in 7-day group and 15 in 14-day group. And the median number of antibiotic-free days by day 28 was found to be 19 and 14 respectively for both the groups. Again, the confidence interval was 2 and 5 respectively. So secondary outcome measures were, again, as I stated previously, length of stay, vasopressor use, mechanical ventilation use, median antibiotic-free days, C. difficile infection, secondary infection or colonization with resistant bacteria, and antimicrobial-related adverse outcomes. They were all found to be similar in both the groups. Again, results of the secondary outcomes, this is based on the difference of the confidence intervals. So they have all been plotted in the far right corner of the table. And you can see that for the 7-day group and the 14-day group, they happen to be similar. Now, moving on to the subgroup analysis, here the urinary tract infections which have formed the maximal load of infections in the patients have actually not like their forest representation here is somewhere here. So it doesn't show significant invasiveness. I'm sorry, I'm not able to word it properly. Sorry. So moving on to the subgroup analysis further on. This is the same chart which tells us about the source of bacteremia, the vascular catheter, the intra-abdominal and hepatobiliary, which we had discussed before, and tells us about the hospital and community acquired infection rate. Now, results were consistent across ICU versus non-ICU patients. There was no difference based on infection source, that is urinary tract, lung, intra-abdominal, and no difference based on the pathogen type, that is gram-positive versus gram-negative. This we are talking about the subgroup analysis. Now, in the subgroup analysis, again, ICU versus ward was found to be non-inferior, community versus hospital-acquired, non-inferior, gram-positive versus gram-negative, non-inferior. And severity, which was based on the Apache score of less than 25 or more than 25, was found to be non-inferior. This is a graph which tells us about the mortality rate change over time. And you can see that they run almost parallelly, the red one being 14-day treatment and the blue one being the 7-day treatment. Now, discussion and key takeaways from the balanced trial are as follows: that 7 days of antibiotic treatment was non-inferior to the 14 days of 90-day all-cause mortality. Non-inferiority was confirmed across intention to treat analysis, per protocol analysis, and modified intention to treat analysis. Now, comparison with the previous trials state that there were 3 trials which were done with a much smaller sample size. They also found that 7-day treatment was non-inferior. Now, the previous trials had excluded ICU patients and required clinical improvement before enrollment also. And the balanced trial extends evidence for shorter antibiotic duration to critically ill patients. Now, talking about the strengths of the study, the study is designed with patient-centric outcome. It is a multi-center trial inclusive of wards and ICUs. It increases the generalizability. It is the largest trial looking at antibiotic duration up till now. Similar baseline characteristics and minimal attrition is involved. Moving on to the weaknesses, predominantly Canadian patients, 76% of the patients were Canadian. Maximum patients having UTIs, 40% of study population were having UTIs. Significant non-adherence rate. Then no mention of patients whether they were already taking empirical antibiotics or not. And patients having Staphylococcus infections were not included. Now, conclusions and clinical implications. The 7-day treatment was non-inferior to the 14-day treatment for bloodstream infections. No significant increase in mortality, relapse, or secondary infections. Clinical implications, further studies needed for individualized treatment durations. Moving on to the critical appraisal. The study validity. Was the purpose of the study conveyed plainly and rationally? Yes. Were the objectives of the study clear? Yes. Was the study design stated and adequately discussed? Yes. Now, moving on to the methodology, was the trial protocol and the statistical analysis plan published before the enrollment? Yes. Was there blinding? No. Was funding involved? Yes. It was funded by the Canadian Institute of Health Research and others, which I had mentioned previously. Were the baseline characters amongst the patients similar? Yes. Was there a control population or a comparison group identical in all aspects? Yes. Possible bias? Yes. Now, moving on to the results. Sample size, estimation and power calculations, yes. All the basic data adequately discussed, yes. Outcome measures properly defined, yes. Were the confidence intervals reported, yes. Was there dropout data, yes. So, all study limitations were discussed. Well, I would say that some of them were discussed, but they were focusing more on the strengths of the study than the limitations. And are the study results applicable to the local population could be a point of discussion for us. Thank you.
Great, Shivani, great. Thank you. Thank you for finishing up on time. And maybe now we can take the questions. Do we have any questions, or maybe Dr. Rakesh can directly, take
Right
the
now,
lead?
we don't have any questions, Dr. Manish. I think.
Okay. So, do we have any questions from the group otherwise? Dr. Rakesh, sir?
I think we can start with Dr. Saurabh. He must have something in his mind. Yeah.
Yeah, please, Dr. Saurabh. Sir, you're on mute.
You're muted, sir.
I think students are majorly the part of the group. So I think one question is that why the non-inferiority trial was selected in this study population. Can superiority trial be selected in that population? Shivani, would you want to answer?
Yes, sir. So thank you for this question. And sir, the superiority trial could not be chosen in this study because no placebo was involved in comparisons of the 2 arms that were being compared. So a superiority trial would only be possible if we would have compared the 7-day the antibiotic period with the placebo and the 14-day period with the placebo. So that could have not been ethically possible in this study design. That is why a superiority trial was not possible.
So basically, it was a non-inferiority trial, and non-inferiority trial means that new treatment which we are thinking right now is 7 days trial comparing to the 14 days which we are considering as a standard treatment is basically not worse than the established trial. And generally, superiority trial can say that whether this treatment is equivocal. Maybe it comes out to be that it is inferior to the present treatment which we are giving. But non-inferiority trial is generally being done in these kind of situation when we can't ethically choose a placebo. Dr. Rakesh, do you want to put a light on this, I think, for the students?
I think it's okay to stride. Obviously, this will not be a good option. But then when we try to use the antibiotics judiciously, it becomes difficult to compare head-on and say superiority. So I think it's maybe acceptable to say non-inferiority because there are many lacunas actually in this study which probably is not there. So probably if I put it and consider those lacunas, non-inferiority may be acceptable because the management protocol, if you talk about antibiotic stewardship, they're grossly absent in the paper. So they are just talk about days. And Dr. Shivani, for that, sir, with your permission, can I just?
Yeah, definitely.
So when we talk about this paper has talk about 2 durations of antibiotics, and they have done the fixed durations, 7 days versus 14 days.
Yes, sir.
And if we see the method section which you described and mentioned in the paper, this is a good paper otherwise, a big paper. Now, there are certain major concerns. So when we say in the critical appraisal, is it acceptable to our setting? So I will say grossly no, because out of 36,000 patients they have recruited, 70% of patients have been excluded.
No.
So I think 70% exclusion, I cannot run my ICU, onco ICU, if I exclude 70% patient because my 90% of patient will be from the excluded parameters. And if we see our Indian population, because this study is from probably from Canada, so if we see our ICUs, probably the bacteremia that we have shown will be seen into our populations. Patients will be immunocompromised. And I put it because these patients will be some having nutritional deficiency and other issues. So they will be immunocompromised. So all those patients has been excluded, a big number of 70%. So first major issues when we say, is it applicable to our clinical practice? I will say no, because what I see in my clinical practice, what you see in Artemis, what you see in Medanta, what you see in SGT, they have been excluded, right? The tertiary care ICUs. So we should be very cautious in verbatim to attend. Second, Dr. Shivani, just you can clarify, when we say the antibiotics escalation and de-escalation, it is based on only the cultures that we have, or do we use other parameters to say that, no, this patient would require 10 days of antibiotic, or I should start de-escalating on 3rd day, or I should think of 14 days. So this is grossly absent. Can you just clarify this aspect?
Sure, sir. So, sir, the choice of patient has been based on the culture. As soon as the culture has been positive, they have enrolled the patient into the study. But the choice of antibiotic rests completely with the clinician. It's the clinician's discretion, how much antibiotic, what strength, and for how long would the antibiotic.
That I agree that this is the institutional antibiotic policy.
Yes,
they
sir.
will decide antibiotics. That I agree.
Yes, sir.
But the decision of starting the antibiotics, what I will ask direct question now, is it just based on the cultures and antibiograms, or are we looking for various biomarkers in deciding that this is a time to de-escalate antibiotics, or this is when we are moving from broad spectrum to a specific cultures? This I couldn't find in the paper.
Yes, sir. And neither could I, sir. I couldn't find that in the paper. So I don't think they have.
Just to add on here, Dr. Rakesh, because if you see the inclusion criteria, they have included the sepsis 3 definition before they have taken the patient for the criteria to initiate the antibiotic. So it is done on the basis of clinical suspicion. Sepsis 3 definition has been included as far as the initial enrollment is considered. And generally what they have understood that unless and until the patient has a complicated infection or any specific exclusion criteria, like the patient is neutropenic sepsis, immunotransplant, more specifically the gram-positive sepsis, there they have excluded clearly. And what they have seen, if you stop them arbitrary at 7 days, it's not going to be, it's non-inferior in comparison to the 14 days when you have given it. Yeah, please, Dr. Saurabh.
Yeah, so I just wanted about the generalizability which Dr. Rakesh was talking about. See, I know the exclusion criteria have already been included in onco ICUs, and maybe different ICUs might not be able to take this. But if I say still the data is quite huge in the present scenario, one thing which we need to give it to them. Second is they have actually done intention to treat per protocol analysis and modified intention to treat, and in all those things they have kept a non-inferiority margin 4%. That can be a matter of debate whether it is still more or large, but if you look at the previous study, it is still lesser than what the previous studies were stating at around 10%. I think the take home message for me as far as generalizability is concerned, for milder infection, those infections from which the source is urinary tract infection and then it moves to bloodstream infection, I might be preferable to use antibiotic for a shorter duration of time. But if you go to the subgroup analysis, and actually the subgroup analysis, I think we have stopped sharing the presentation, but if you look at the subgroup analysis itself, all those sick patients, the graph actually crosses the midline. So if you look at Apache more than 25, it actually crosses the midline. If you look at, if you can just show, I think Shivani is trying to show that.
This
Okay,
one.
if you can just stop that at that level. So if you look at if the patient has got any other kind of infection, whether it is lung infections, whether it is intra-abdominal infections, or even for other infections, it is crossing the midline. So if you look at those things, so for the generalizability aspect, I can say that if the patient has got a milder infections like urinary tract infections, and it has been turned out to be bloodstream infection and the source is UTI, then I can say probably I can use it, but maybe I'm not very much keen to use it in other infections. Okay, so that might be a takeaway with a caveat as well. I think this is what my take on generalizability in this paper.
So I fully agree with which Dr. Saurabh mentioned. I'll put it now when we do a subgroup analysis and try to see this graph which crosses the inferiority margin by 4 days here. Now, if we talk about the individual, they have not given the cumulative here. They are all underpowered. So if you see the UTI, this is approximately patients are around say 750, 1000. So now they are all underpowered. So again, the generalization becomes a big issue because they have done subgroup analysis. This is one. So again, though they are not crossing the inferiority margin, because of the underpower, it's become difficult to comment upon that they are useful or not. This is one. Second thing is, when we say acceptable to our population, we need to understand that almost 42.2% were the urinary tract infections and 18 were biliary and abdominal infections. So almost is crossing 80%, 60-65%. So just check your ICUs that the majority, half of your patients are admitted in ICUs with urinary tract infection. In my ICU, it is mostly lung infections and the abdominal infections. So probably I will not be able to translate this generation into my ICU. So it's all dependent upon the type of ICU you're working. Third thing is, which is a little worth mentioning here, they have used median and interquartile range. So this means that their data was skewed data. So when we use median, we use non-parametric test, and non-parametric test, the reliability of the outcome is very poor. It's not robust as when we apply the parametric test for the statistic analysis and confidence interval. So it itself goes down. And they have mostly reported median and interquartile range. I could hardly see mean for any of the primary outcome and secondary outcome, though they have reported risk difference. So that's the strength of it. So it's probably to a certain extent nullify the statistical aspect, but still from the statistical output point of view, it becomes a little weak. Third point, Dr. Saurabh can comment upon, or Dr. Manish or Dr. Neeraj can comment upon. When we talk about the antibiotic, probably it's not just 7 and 14 days. Are we thinking of some therapy, some intervention, some biomarkers, some clinical diagnosis, where we start thinking of de-escalation or escalation of antibiotics, which they have not defined into this, which clinically we do. So I will leave it to Dr. Saurabh and Dr. Manish or Dr. Neeraj to comment upon this aspect.
Shivani,
Right,
before we go to this question, I just wanted to show your adherence protocol. That is also one of the major weakness of the study.
Sure.
24%.
If you just, almost 1/4 of the patients actually cross the group. If you look at that scenario, they have defined it plus minus 2 days for a 7 days period. It is from 5 to 9 days they have taken, and for 14 days period they have taken 12 to 16 days. So if 25% of the patients in a shorter treatment group, if they are going to cross for 2 more days, they are going to obviously cross to the next group. So I think this non-adherence to the protocol also makes a significant difference in taking the generalizability account. I think this is also a major weakness.
Yeah, Dr. Saurabh, just to add that the major challenges for a non-inferiority trial is adherence, right? Because many of the time, these patients, if you are doing a non-inferiority trial, the first most common challenge in these groups of patients are mostly either due to the discontinuation of the treatment or non-adherence to the policies. So that's why they have very clearly mentioned in their part also, because non-adherence is their main limitation. And another question about that, the amount or the quality of the patients like UTI, they have already committed in their limitation.
This already has been.
That our limitation is that related to that.
Yeah.
Shivani, you can stop sharing the slide, I think.
So
As
I
regards
think
Dr.
I will just
Rakesh
take
question-
another just 2 minutes, because I just
Yeah,
want to know
yeah.
from more of a clinical plausible question for the clinicians. So help me in understanding one of the major reasons why we want to reduce the duration of antibiotics, so that the antibiotic related adverse events in the form of Clostridium difficile infection, in the form of the development of MDR extra infections, and the possibility of secondary infection is what is one of the secondary outcome which was seen. Now help me in understanding that whether you give 7 days or you give 15 days, they have seen there is no virtually change. So how will you explain it? Generally, we are expecting the patients who are on, the longer duration of antibiotics, they have more incidence of secondary infections. More specifically, Clostridium difficile has been the biggest reason they have cited. And that was the major hypothesis, apart from the mortality benefit, which was taken into the initial consideration. So this is something which has given me a setback, that how come, despite of the fact they have taken 3,600 patient plus, and they have not seen virtually any increase.
I will come to Dr. Rakesh's question also. Sir has asked about that. What are you using in your ICU if you go to the clinical generalizability of the study? So if you look at, I think there is enough awareness about antibiotic stewardship, at least in kudos to the different society, and the main society is in ISCCM. So we know right now, longer duration, I think everybody is not going towards a longer duration unless and until you are not aware of the side effects which Dr. Manish is talking about. So if you look at our ICUs, what we used to do is that if we are sending procalcitonin on the day 1 of the infection, I generally, and we are starting, I'm talking about the patient of sepsis or septic shock, okay, those patients we generally encounter in our ICU. I'm talking about the ICU population. So in those patients, what we usually do is we do a procalcitonin, and after 24 hours, we generally see whether 24 or 48 hours, we generally see that whether it has got a decreasing trend or not. If it has got a decreasing trend, I know that my empirical antibiotics, and clinically also the patient is showing that that improvement in decrease in vasopressor dose and all those things. And maybe after cultures, we all de-escalating to the specified antibiotics, which should be for that specific infection. And we are generally stopping after 7 days. After 7 days, there should be a particular reason, like in my ICU, it is meningitis commonly. So there should be a particular reason why you are continuing. You need to answer that question in an affirmative and with logics and with things. Otherwise, we are not giving antibiotics in our ICU. And moreover, generally, why I'm talking about procalcitonin, because with our labs, we have made that that the amount of money should be going with 3 sets. So we generally have a liberty of setting 3 sets, and we have made that. So after the third set, we are sending is at around 5th or a 6th day. And I'm very confident that if it has been decreased to 80% of the previous procalcitonin, I generally able to stop that antibiotics. And even for that sake, if it has not decreased to that pre-specified limit after 7 days, there should be a very strong reason to.
I think that's a very valid point which Dr. Saurabh has said. Dr. Rakesh, it's not about 7 or 8 or 9. Idea is basically shorter duration of antibiotics, because I still remember, and Neeraj will agree with me, when we were there as a training in critical care, way back in 2003, there was a benchmark paper for ventilator-associated pneumonia, 8 days versus 15 days.
Yeah.
And then everybody started promulgating 8 days. Idea is to keep it as short as possible. And of course, it has to be clinically supported as well as biomarker supported. Now, let's go to the second. My question has still been unanswered. If we have a time, then I would like to know from Dr. Saurabh or maybe Dr. Rakesh, and even, Neeraj or Abhinandan and Shivani can, reflect upon later on. So right now we have Abhinandan. Yes, Dr. Abhinandan, please go ahead. Thank you. And we have to finish off by 8:05, overall this exercise, please. Abhi, we cannot hear you.
Hello. Am I
Yeah,
audible?
yes,
Audible, yeah.
now you're
Yeah.
okay.
Is the slide visible, sir?
Yes,
Yeah,
slide is
visible.
visible. Make it full screen, please. Abhi,
Yeah.
there is a
Is it
yeah,
visible now?
Yeah,
Yes,
visible.
perfect.
Please go ahead. Yeah.
Okay. Very good evening, everyone. Thank you for this opportunity, Manish sir, and thank you, Rakesh sir, for guiding me through this. So today I'm going to present in this session a paper. Basically, it's microcirculation properties of 20% albumin in sepsis, which was a randomized controlled trial. It was carried out by Rachel A.F. Cusack et al. At St. James Hospital in Dublin, Ireland. It was published in the Journal of Critical Care in 2025. And basically, the trial was to investigate the effects of 20% albumin versus crystalloid fluid resuscitation on microcirculation in fluid responsive shock patients. So this study basically the primary outcome was microcirculation improvement, which was measured during by using a side stream dark field camera and AVA 4.3 software. As we all know, sepsis is a complex immune response to infection with a global incidence of 26 to 30% and mortality rates of around 17 to 25%. To trigger the triggered cytokine storm, increasing the vascular permeability and causing tissue edema, contribute to the organ dysfunction. A damaged endothelial glycocalyx impairs the vascular integrity. This can be assessed by the microcirculation visualization, and impaired microcirculation marked by flow heterogeneity and edema hinders the oxygen delivery to tissues and worsens the sepsis outcomes. Now, patients with worse microcirculation on admission to the ICU have longer length of stay and higher mortality. Now, the role of albumin is essential in stabilizing the endothelium. It reverses the oxidative damage and also carries glycoproteins to restore the glycocalyx coherence. Low albumin plasma levels are associated with worse outcomes in sepsis, which has been demonstrated in various studies. Now, replacement therapy has not been significantly shown to improve overall morbidity and mortality. This can be attributed to largely heterogeneous nature of the trials with albumin, and so it called for more research into clinically relevant organ-specific effects. So the hypothesis in this study was that albumin-based colloid resuscitation could improve the microcirculation in sepsis by repairing the glycocalyx. Now, the objective was to compare the effects of 20% albumin versus crystalloid bolus on the microcirculation in septic patients. Now, better microcirculation correlates with improved outcomes in sepsis, and they aim to investigate whether 20% albumin by stabilizing the endothelium can improve the microcirculation. So coming to material methods, the study design was basically prospective, randomized, and partially blinded study. It was conducted from January 22 to July 23. And it was aimed to assess the effects, as we already saw, on circulation. And this study was registered with the clinical trials. Now, recruitment and inclusion criteria, patients basically were the fluid responsive patients, which had sepsis 3 criteria for septic shock, and they were more than 18 years of age. Patients were intubated, and which standardized the flow placement, and also pulse pressure variation assessment was valid. So there was also a criteria that the intact oral area should be there for side stream dark field analysis. Is the camera probe is actually placed sublingually. Patients were sedated but not paralyzed. A primary outcome, basically they wanted to see the difference in the microcirculation between the two groups, 20% albumin and crystalloid, and it was assessed by the SDF camera. Now, power calculations mandated that a sample size of 42 patients per group to detect a difference of 20% on microcirculation changes at a power of 80%. Recorded outcome measures were microcirculation, macrohemodynamics, fluid bolus volume, fluid balance, mortality, and length of stay in the hospital, ICU. So this is basically a bit technical, but I can run through a little bit. If you can, basically, what the camera does, it maps a certain area of the mucous membrane, wherein there are crossing capillaries, arterioles, or venules, and there is a grid. So basically, number of crossings of those vessels in the grid is the number one parameter. Then there is a entity called Debacker density. It is basically the number of crossings of these vessels per unit area. And also for the smaller vessels, they have made number of crossings small and Debacker density small. That is for less than 20 micrometer, which is usually capillaries and includes the venules and arterioles. And also there is another parameter, perfuse number of crossings, perfuse Debacker density. This is basically they see the observable flow, whichever how many capillaries have the flow inside of them. It can be visualized with the camera. And also perfused Debacker density small, and also perfused number of crossings small, which is the smaller capillaries, less than 20 micrometer. Also, there is two other parameters, consensus PPV. This is not pulse pressure variation. It is basically proportion of perfused vessels. So in the same way, it is also the larger and the smaller ones. So fluid responsive assessment was assessed using two methods. They use either pulse pressure variation, and for patients with arrhythmias, they use the passive leg raising test. So pulse pressure variation of more than 12% indicated the fluid responsiveness of patients with tidal volumes of 8 to 10 ml per kg. And for PLR, they measured changes in stroke volume index. Now, the intervention they did was fluid responsiveness, fluid resuscitation after the assessment of fluid responsiveness. They were randomized to actually receive either 20% albumin or isotonic crystalloid. It was carried out with accordance to the local procedures, and anything apart from the albumin or crystalloid was governed by the local protocol. There was no change in either groups. Fluid boluses were administered until no longer fluid responsive. That is the target PPV of less than 12. Now, blinding. Here, albumin and crystalloid packaging and administering volumes were not blinded, but the allocation and also the microcirculation image analysis were performed in a blinded manner. The analysis software was also unaffected by patient allocation. Microcirculation was assessed using the side-stream dark field camera, which provided real-time visualization of the microvascular structure, density, and functionality. The sublingual probe was used, and it was measured at 3 time points, basically. Before resuscitation, time 0, 15 minutes after fluid responsiveness, and return to baseline, 15 minutes after return to baseline, and also 1 hour per fluid bolus, that is time 60. A single assessor performed all the scans to minimize the inter-observer variability. Now, endpoints. Basically, endpoints were the primary endpoint was improvement in microcirculation, measured by changes in capillary flow and density after fluid administration. Microcirculation measurement was triggered by improvement in macrohemodynamic targets. Time points were time 0, time 15, and time 60. Secondary outcomes included ICU length of stay, vasopressor requirements, and 28-day mortality. Now, coming to the results, the patient characteristics, as we can see, basically the mean age was 58, ranging from 18 to 86. The most 35% of the were females, and other parameters were mostly similar. There was no difference in the SOFA and Apache score, mostly no significant difference in that. And here, one thing I would like to point out is that the most common comorbidity was hypertension, followed by COPD in these group of patients. AKI was prevalent. They mentioned that 50% of the patients in both groups, due to multi-organ dysfunction, had AKI. Patients were admitted with either abdominal or respiratory sepsis. They have not included any other, they have not actually mentioned So they said 43% was abdominal sepsis and 39% were respiratory sepsis. So there was no significant difference in the severity of sepsis as seen by SOFA score. And also there was one thing that they mentioned, that the control group had little bit higher SOFA and Apache scores on admission, but significantly statistically significant, not statistically significant. So in the primary outcome in microcirculation, basically they were obtained from the various sublingual areas, and changes across time points in each group were validated for each variable. Now, for analysis of variance, they did not find any significant differences in the variables, but paired t-tests, they showed significant changes from baseline in the number of crossings and Debacker density during resuscitation, and also at 15 minutes in the albumin group. Now, in this study, they have mentioned that for comparative purposes, they have not used the Debacker density during resuscitation later on, saying that the patient actively being resuscitated was not, they were not able to. But here they have mentioned that it made a difference. I could not correlate actually. Control group that received crystalloid resuscitation did not exhibit any statistically different significant differences in microcirculation. But in the albumin group, the changes in perfused number of crossings and perfused Debacker density were statistically significant during resuscitation at 15 minutes, but not at 1 hour. The perfused number of crossings small and perfused Debacker density small, that is the capillaries, were only significant from baseline at 15 minutes. Now, the consensus proportion of perfused vessels and CPPV small were statistically different from baseline at 15 minutes. Now, if we see the difference in volume of fluid administered, we can see that the albumin and control group did not have a lot of difference with no significant statistical significance. Almost a similar amount of fluid was given. Total fluid boluses, fluid balance, or even 24 hours fluid balance was the same, almost comparable. So if we see also the vasopressor days, hospital length of stay, mechanical ventilation days, length of antibiotic treatment, ICU length of stay, they have mentioned that there was no statistically significant differences and they were quite comparable. And also the macrohemodynamic outcomes were comparable in both the groups. They used the parameters of heart rate, MAP, and also things like lactate, noradrenaline, which was used, the pH in the ABG, HCBO2, but they were all comparable across both the groups. So they use linear regression analysis to evaluate the differences. But they also mentioned that the albumin group's microcirculation parameters started from a worse baseline compared to the group. So to account for different start points, it tested the differences in the change in microcirculation from baseline between the two groups. So they saw that the Debacker density positively increased during and 15 minutes after the albumin resuscitation. And it was not significant at 60 minutes though. In the control group, only at 16 minutes, there was some change seen, which was significant. Number of crossings for the capillaries and perfused number of crossings for the capillaries increased significantly at 15 minutes and 60 minutes in the albumin group, which is significant. Also, for the perfused and capillary Debacker density, the CPPV and CPPV small in the albumin group were significant changes from baseline in the albumin group. So in all variables, the albumin group exhibited a greater slope. The goodness of fit test was done for all the models, indicated that significant fits for the albumin group, whereas only 50% of the models for the control group showed good fit. Secondary outcomes, basically, as we discussed, there was no significant difference in all the parameters, fluid volume, length of stay, and also macrohemodynamics. So in conclusion, this study basically uniquely demonstrates that a 20% albumin bolus improves the microcirculation in fluid responsive septic shock patients independent of its microcirculatory effects. The improvement in microcirculation in the albumin group was statistically significant compared to the control group. Furthermore, the albumin group's superior microcirculatory recovery at both 15 and 60 minutes post-resuscitation provides further assurance that the findings reflect the true therapeutic effect of albumin. Now, for a short critical appraisal, did the study address a clearly formulated research question? Yes. Whether 20% albumin therapy by stabilizing the endothelium can improve microcirculation was the question. They selected septic shock patients. The comparator was crystalloid, which is clear, and the microcirculation assessment by SDF camera was precise. Randomization of assignment of participants was done using the online computer system, and randomized allocations were securely stored in opaque envelopes, maintaining allocation integrity. There was no loss to follow-up among the patients. Patients who recovered were followed up in the ward to complete the consent process. One patient withdrew consent and their data was removed from the records. So the total number of patients has been the same. 2 patients were removed from the study as their images were suboptimal. So basically 100 patients were there. While the participants, albumin and crystalloid packaging and administered volumes were not blinded, but allocation and microcirculation image analysis were performed in a blinded manner. Study groups were similar, compared at baseline to identify potential differences. Basically, the parameters were mostly similar. And also, the same level of care in each group, apart from the experimental intervention, was given. Apart from albumin and crystalloid, all other treatment modalities and were local protocol followed. So power calculation was done prior to the study. Outcomes measured as parameters detecting microcirculation improvement, and there was a clear-cut time intervals at which the outcome was reported. Data was complete. Analysis of variation for normally distributed continuous variables was used, and man-Whitney U for the non-normally distributed. To analyze the changes in microcirculation, linear mixed effect models were used. P-values were reported, but confidence intervals I could not see in this study. By and large, to conclude, we can see that the results of this trial can be expected to be duplicated if we see the patient's demography and also the sepsis patient. It may be actually considered that the results will be duplicated in our population, but it remains to be seen if the prohibitive cost with regards to 20% albumin in our setting will stand in the way of it being widely used. And also, lastly, they have the declaration that they were funded by Bruce also. I don't know if there is a this study can be. I think it needs further debate. Thank you.
Great, Abhinandan. It's a tough paper to explore. And of course, we have a toughest mentor with you who's going to help us in understanding. And of course, sir, we'll do it within stipulated time. That is my request.
Sure. Yeah. So I requested for 10 minutes extra today, but anyhow, I will finish by 8.
I have few questions. Just remember, sir, I have 2-3
sure.
questions for you. Yeah, please.
Agreed.
Please,
so I'll say this is a very good paper, in fact, and for the fellows who are listening to this, I will suggest you just go through the glycocalyx model. So if you remember around a decade before, we were talking about tubular vascular structures and we think it's a pipe, heart and a pipe, and then we used to treat it, and there are some capillaries. Glycocalyx model is actually a very complex model, and it has a lot of implications when we talk about critically illness. Now, this glycocalyx, which holds the water into the tube, is like a sponge, which is there inside the vessels, and they can be damaged by any type of inflammatory cascade or a septic cascade, and they behave very differently. So this is one. So all fellows must read what is glycocalyx model. What are the factors which can affect the glycocalyx? What are the factors which preserves the glycocalyx and retains the? So it's not the colloid oncotic pressure or osmotic pressures. It's the glycocalyx also which retains water. This is one. Second, this study has been done in a very robust way. Though it's a small sample size, they have calculated the sample size, but it appears to be a small study when we talk about fluids. So probably I will look this way that though calculated sample size, but still we need a multi-centric study so that we can be robust about the outcome parameters. Now, whenever we compare objective, the outcome, it has to be measured through a robust outcome, which they have used it. The tool they have used, the camera and looking for the microcirculation, this is giving a good tool, and this tool is validated. Simultaneously, they have looked for the other predictors of microcirculation, which is like lactates, pH values, and other things. So both are corroborating. So again, this appears to be good. And the fluid resuscitation, against it was objective. So if you see the recent literature, say in 2025, probably the passive leveraging test and PPV, these are the good indicators for giving fluids or managing fluids or how much to boil. So they have used it. Only one concern is, in their patient study, which Dr. Abhinandan mentioned, majority of patients were having low albumin levels. So it was somewhere around, I think, 27 gram per liters. So they were on the lower level. And in the inclusion criteria, it was not that only the albumin low levels will be given. So sometimes those patients who comes with early sepsis and albumin levels may be okay, the synthetic function is okay, will this study be applicable? We are not very sure. So probably when, say in India, if we say any albumin less than 3 becomes an indication to supplement that. So probably we should look this way, that in those patients who has an albumin level of more than 3.5 gram per deciliter, probably this supplement may not hold right. This study may not hold right. So this is one aspect that we need to look for. Otherwise, I think a good study, and various parameters, even the surviving sepsis guidelines is also supporting the use of albumin in the selected patients. And the good part of study is that this is a pragmatic study. This means a mixed ICU. So this is across the different cadres of patients coming to them. So we do not know that probably albumin may be beneficial if somebody is coming with hepatobiliary cirrhosis, hepatobiliary sepsis, or with lung dysfunction. So we do not know about those parameters. But it appears that anybody less than 3 gram per deciliter of albumin, probably during resuscitation septic shock, albumin may be considered, and it is considered a little shade better for the fluid resuscitation if a patient comes into sepsis 3 criteria, which they have included. So I think I'm on time, Dr. Manish. And
No, thank you, sir.
Request Dr. Neeraj and I think Saurabh Bose has left. He's here.
He's a busy man. You know, he has to see a lot of neurological cases. So
And
he's
yes,
managing
Saurabh
his
is
neuro
here.
ICU.
He's here.
Sir, I myself have a question, if you may allow me.
Yes.
Actually, going through the study, I wondered, because generally 5% albumin for resuscitation
Yeah.
is a different matter. 20% albumin in such large volumes, they have used just like crystalloid. So, like, how much is it feasible, or like how much is it?
You know, Abhi, I was about to ask the same question. You know, we need to understand, you know, this study looks very interesting when you see it as a paper. The Surviving Sepsis Campaign guidelines, which are basically taken as sacrosanct with the resuscitation, has defined certain volume, right, Neeraj? 30 mils per kg is what they have given as an initial volume-based resuscitation. Now, with the context that, you know, or maybe you can use 4% albumin, this is what they have been endorsing. Now, this is the first time we are seeing, or maybe, you know, very rarely, we are seeing an endorsement where they're using 20% albumin as initial boluses. We don't know the volume which they are going to give. So it is very difficult. But what they have taken is, they have taken pulse pressure variation as the endpoint of your resuscitation, which means you shall keep on giving the 20% albumin till the time you're the patient who is sedated, being ventilated, has a pulse pressure variation certainly less than 12%. Now, this looks very interesting if you're in a research-rich settings. Now, this may not be, applicable when it comes to our, the clinical setups, especially in the government setups where you have, the resource limitation. It may not be there in All India Institute of Medical Science, but majority of the government setups, you will be fighting for these resources, right? Now, just to go forward, Dr. Rakesh, Dr. Neeraj, Dr. Abhi, and other respected audience, when I went into the literature, there are 2 papers, the SWIPE study, which has got published, I think, in 2018. And there's another good meta-analysis where they've actually compared the volume, where they've compared the concentration of albumin for using the resuscitation. And what they're talking about, the sepsis resuscitation is no more a volume-based resuscitation. It is actually the use of albumin, as Dr. Rakesh has elucidated, it's beyond just the macro resuscitation. So when you're using albumin, you're stabilizing the glycocalyx. And the whole pathophysiology of sepsis in the recent 5 years has been changed, has been metamorphosed because of the same reasons. So the glycocalyx is what they're talking about, because nowadays the resuscitation is much more limited by volumes. We were very, very liberal in the past, and now we are very, very guarded, right? And the role of colloid like your albumin helps you in limiting the volume, not only limiting the volume, but also to stabilize the glycocalyx, which eventually is responsible for increased capillary permeability and hence your volume overload, which you tend to have features, right? So this may not be applicable in our setup, as I said, because of the cost issues. And hence, I don't know. But one thing is very clear, which I'm able to learn from you, Abhi, and of course, Dr. Rakesh. Albumin is becoming a big, important treatment strategy, and the role is beyond your cirrhotic patients, HRS, or patient with SVP. I'm working in liver transplant, so it is beyond the liver ICUs. And just to add one more, the only evidence-based study in the past which has supported the use of albumin in sepsis is the Albios study. So there they have used a cutoff of 25 grams per liter as a cutoff, not 30 grams per liter otherwise. So with all the patients who have been really septic, with septic shock, and the serum albumin is less than 25 grams per liter, they were the candidates who received the albumin therapy. So try to use the albumin in case if you have one. The second is that make sure there is certain methods to guide the volume-based resuscitation, like in this case, pulse pressure variation. The third most important is that be aware about the serum albumin levels. So sickest the patient, probably better will be the use of albumin, and less sicker patients, less use of the albumin should be.
Just to add to it for our listeners also, that there is a concept for that capillary stress, right? So in this study, what they have not mentioned about that the delta change in the pressure, that what pressure in septic shock patients, the problem will be there, because there are we have understanding that there is a capillary network of which there are pre-capillary arterioles, then capillary bed, and then post-capillary venules. And what happens most of the time, they have a very high degree of structural you can say heterogeneity. So what happens many of the times, because the microvascular flow is basically controlled by the viscous force. So if viscous force or microvascular shear strain, because it's a very beautiful study that I was reading while going through this article, then I just got to know about that force balance equation, which is very, very fine-tuned about this microvascular shear stress, where they basically captures about the delta P change in the pressure difference across the capillaries, which is very, very important, because they have done a delta P changes for septic shock patients for checking that capillary shear stress. So I think it's a good study and a very robust study, which we can definitely. It's not easy, because I was searching for that SD camera machine device also. It is not available on the Google, on the videos also. The videos is not available, because the D Baker density has to be understand, and it's a total physics that is involved in it. Per square inch multiplied by 21, then how will you check for the capillary crossings and all. So I think, but you tried very well, Dr. Abhinandan, and it's a really pleasure to have you all. Dr. Manish?
Yeah. I think, as you said, Neeraj, it's a wonderful work, Abhinandan. And of course, you have the best mentor with you, so you were supposed to deliver best. So Dr. Rakesh.
Can you just stop that presentation, Dr. Abhinandan? Yeah, please.
Yeah. So now, do we have any questions, Dr. Neeraj?
Yeah,
do we have any questions? Do we have any questions to answer?
By the time each checking, Abhinandan, can you just mention in the supplementary material? So when they were giving fluid boluses, they must have given crystalloid in both the groups.
Yes.
It was boluses. It was crystalloid for both the groups, or it was only.
No, crystalloid group got crystalloid. They gave basically compound sodium lactate. They have mentioned it, and it was used exclusively for the crystalloid patients.
So
and
have they given
patients, not only albumin, sir?
No, sir. They have used exclusively albumin. So thank you. And now Neeraj has an important things to not announce, in fact, to share with each one of us because of the untimely death of Professor Rinaldo. Please go ahead.
I'll just take 2 or 3 minutes, because I think a pioneer who has died, and Professor Rinaldo Bellomo. I think entire ICCM member are deeply saddened by the untimely passing of the Professor Rinaldo Bellomo on 7th of May 2025. And he itself a pioneer in intensive care medicine and critical care nephrology. And Professor Bellomo has already a visionary whose groundbreaking work has reshaped the field as well as inspired our countless clinicians and researchers globally. And his scientific contribution were really monumental, and his dedications to the patient care is unparalleled because his professional excellence he devoted with a family man as well. So I'll just quickly go what he has done for our intensive care society. He was born in Italy, 8th August 1956. He's an intensivist physician scientist, a professor of medicine, University of Melbourne, and he's a co-founder of Australian New Zealand Intensive Care Society Clinical Trials Group. He has more than 18,000 scientific publications with till he died. He has 1 lakh citations, and his legacy that he revolutionized the ICU research methodology, deeply respected for his intellect, humility, and humanism. And he named on the Claveret Analytics list as the highest cited researchers in the year 2014 and 17. Just I will talk few landmark work that he has done, that he has defined the rifle criteria, definition for rifle criteria, and he reduced the term the rifle criteria, which was published in Critical Care in 2004. Then after that, he has published another fluid resuscitation issue, because today we are talking the fluid resuscitation microcirculatory aspect. So I thought that I should add this. We should pay homage to him. And again, this was a very landmark paper which was published in NEJM 2012. Then after that, again, he published early goal-directed therapy in sepsis as a RISE trial, which was published in NEJM 2014. And then he has again talked about START AKI trial, when to start that renal replacement therapy and what would be the timing. He talked about that in NEJM. Again, it was published in 2020. So I think the last study, which was very popular, that he talked about the epidemiology of AKI, why AKI happens and what are the various risk factors, the best study, which was again published in JAMA in 2005. So we should pay homage to him, and I thought that this was the right platform for Professor Rinaldo Bellomo, and I think we have lost a very big shot in the ICU research and methodology. Thank you.
Thank you, Neeraj, for bringing this to our, because it's a biggest loss when somebody of such a stature we lose in the field of intensive care medicine. So just to go forward, do we have any questions, or can we close the session? Do we have any questions? Okay, so in the interest of time, let's bring it to the closure. Thank you. My deepest gratitude, my love and respect to Professor Rakesh Garg, Dr. Saurabh Anand. Of course, Shivani is one of my closest friends. Abhinandan is always close to my heart. And this whole exercise has been well executed by Neeraj. And of course, the biggest man who has a brain vision for this concept was Dr. Ranveer Singh Tyagi. So, sir, thank you for having such a phenomenal platform where the people from the diverse backgrounds, from the diverse part of this country are there exchanging the ideas from the experts. And for our audience, this exercise, this journal club is basically to be done on every third Friday of every month. So I think the next is going to be 21st of June, 2025, 7 to 8 p.m. So be there to learn from the best of the experts. And remember our intention is to simplify the evidence-based medicine to the bedside medicine, right? With this, I bring it to the closure. Thank you. Namaskar. Hare Krishna.
Thank you, everyone. And
thank you.
Good night.